Hi everyone, it's the top of the hour and we've got a lot of material, so we will dive in. I am David Glazer and I am here to talk about physician compensation issues, why the survey says may be totally wrong. In addition, so we don't have many announcements. First, I'm likely to run over. I've got a lot of slides. The tail end will probably go past the hour. To make sure people can ask whatever questions they want, my colleague Katie Ilton is here, and I'll take questions throughout, so feel free to send them. And we may pause at the proper times for questions. The next webinar is almost certainly be our colleague Kevin Rich, talking about developments in the False Claims Act world. Kevin is a veritable encyclopedia of false claims knowledge and also entertaining. And if I were ever on death row, he's the guy I think I'd pick to defend me. He's just a great lawyer. So he will be doing that. The date may change. It may be the second Wednesday, or we may need a new date in June. So we'll let you know. Finally, to ask questions, hover over the bottom of the screen. The chat box will pop up, and you can do that. And last but not least, if the sound is terrible, it may be the slowness of the internet over the lunch hour. Robert is sending out the dial-in number, and you can use that. So the agenda, we're going to do a brief overview of the laws, then dive into Stark a fair amount, with my main goal being trying not to put people to sleep talking about Stark. In the middle, we're going to talk about salary surveys, and in particular, why the statement, systems lose money on every physician, is a terrible thing to say and an inaccurate thing to say. We'll then go kind of quickly between other sorts of relationships between hospitals and doctors, medical directorships, Gainsharing, and the like, and end with relationships between physicians and organizations like drug and device companies. And one of the challenges of this topic is there will be parts of this, if there are some medical device companies on, the first part of this will be less interesting to them. And I apologize for that, but you can always zone out. I assume people do that listening to me anyway. So the first relevant law is the Medicare Anti-Kickback Statute. And this is one of the easier laws to understand. It's a felony if you make or receive, offer or ask for any payment, and that payment is intended to influence referrals. And the government uses a one-purpose test where they will say, if there are many reasons for the payment, but one of them is to influence referrals, that's enough to make things illegal. Now, one thing that I think is often overlooked is that the anti-kickback statute doesn't apply to payments within a corporation. Now, how do I know that? And I would say that when we say that, people often look at us like we're crazy. But we know it because of this language from the Federal Register. When I was not even a lawyer, I was still in law school when this came out in 1991. And if you skip down to the purple, you'll see that we believe that the statute is not implicated when payments are transferred within a single entity. For example, from one division to another. Thus, no explicit safe harbor protection is needed for such payments. So if you're within a corporation, you can blow off the anti-kickback statute. It is for inter-corporation relationships. Now, in the anti-kickback statute, intent is the whole 9 yards. You just want to keep asking, why is someone doing this? And if the reason is that the compensation is intended to change behavior, that's a problem. So think about when a device company says, we're going to bring pizza into a hospital. Now, many hospitals prohibit that because they think it's an ethical issue, and that's fine. You can certainly choose to do that. But is bringing pizza in to a hospital a kickback problem? And I would say it's not, because that's bait to get someone in there to listen. I don't think anyone believes that the presence of pizza is going to cause the use of a particular drug. By contrast, if the incentive is designed to change behavior, that's a situation to try and to take cover immediately. Now, many of you know I, by hobby, am a storm chaser. And I've got a bunch of storm chasing pictures, including this one. And I think that this is illustrative of the anti-kickback statute in the sense that, actually, this is the anti-kickback statute. Here, you're looking at what either was the first time my son saw a tornado or a really nice cloud thing. Because you can't tell if there's a tornado behind that barn, and unfortunately we never got to a place where we could really figure out if there was a tornado on the ground or not. I think there may not have been. I think it was just a funnel, but we don't know. The anti-kickback statute is not like that. It's much more like this. You can usually figure out if there's a problem under the anti-kickback statute or not. It's easier as a lawyer to do, and it's not that time-consuming or expensive. Anti-kickback things are a 10-minute or 5-minute conversation with the lawyer where you ask why. Now, there are safe harbors under the anti-kickback statute, but they're incredibly narrow. How narrow? Well, there's a safe harbor that protects ambulatory surgical center joint ventures. And when it first came out, we were listening in to a conference call put on by CMS. All of my colleagues were around the table. So that safe harbor says that if the hospital is in a position to refer patients to the ASC, you don't fit within the safe harbor. And in the call, the government explained that basically that meant if the surgery center was in the hospital's service area, the safe harbor doesn't apply. Now ask yourself, will a hospital ever put up an ASC outside of its service area? That would be idiotic, right? So we asked, hey, what does the safe harbor protect? And what the government said was, look, we know the safe harbors, if you're in a safe harbor, we can't attack you no matter how bad your behavior is, so we make them incredibly narrow. And I mention that just to say you do not need to fit in one. You really don't need to fit in one. You usually don't get obsessed about this. I also want to highlight that different lawyers can take a very different approach. I was working on a project recently for a large organization. It's one you've probably heard of. And they were asking if something was okay, and I said yes. And they wanted 2 opinions. So they asked another national law firm for their opinion. And the other law firm said, and I quote, "We didn't find an advisory opinion which suggests that this behavior is illegal." Now, I do not understand where that law firm was coming from. I don't think this is an issue that's gray at all. The absence of a advisory opinion gives you no data about the legality of the process. But a reputable law firm reached the other conclusion. And so I just want to highlight, lawyers are going to give different opinions on stuff. Push us hard to explain why, because we need to be able to do that. So what are the kinds of things that get you in trouble? Well, if a hospital provides a physician a medical directorship without expecting any actual work. And a good illustration of that was Baptist Medical Center in Kansas City, where 2 doctors, the LaHues, were indicted. And actually, in one of those things that makes us lawyers stand up and pay attention, the lawyer got indicted for setting this deal up. It was a long time ago. I want to say 1995-ish. You can't if you can't pay a doctor to do nothing. What if let's try this again. What if a doctor walks into the 2 hospitals and say, hey, if you don't give us free advertising, we're taking our business to the other hospital? That's sort of a classic potential kickback issue. But does that mean every request by a doctor is a kickback problem? If the doctor walks in and says, you need to improve our crummy turnaround time in the OR, otherwise I'm taking my cases across the street, is that a kickback problem? And I would say no, it's not. I don't believe that is compensation to the physician. That's just improving the service. And there are a variety of other contexts where this can come up. And I have to say, reasonable people can differ. I had a fight in the Pacific Northwest with a hospital where the doctors were saying, hey, we would like to have more techs in the OR. And the hospital said, we can't put more techs in the OR because we think it's a kickback problem. And I, on one level, understand the hospital's thought process. But if you think about this for a moment, I've never heard anyone assert that putting in like a new, better operating table or putting in the newest robot is a kickback to the doctors. And that just doesn't seem like it's actual compensation to the doctors, and I don't think that's the right way to look at it. I actually don't know that there's an advisory opinion on that point, but I feel pretty comfortable with it. Now, Stark is many things. It's full employment for lawyers. It makes your hair hurt. It's confusing. It's a chance to put you to sleep. But let me try to explain it easily. If you've got an organization, and that organization provides any designated health service, and we'll list those in 2 slides, and there's any financial relationship between a doctor or anyone in the doctor's immediate family who ordered any designated health service provided at the entity, that financial relationship has to meet an exception under Stark. Now, financial relationships basically fall into 2 buckets. The doctor can own something, ownership, or it can be compensation. And Stark also looks at compensation either that's direct, right from the organization providing the designated health service to the doctor, or indirect, it goes through various people. And more on some of this. Stark is hard. There's no way to pull punches on this. It's complicated. Now, Stark only applies to things that are designated health services on the next slide. But that's a little misleading. We'll come to that in a moment. Remember, every hospital service is a designated health service. So if there's a compensation relationship of any sort between a doctor and a hospital, you have to think about Stark. Stark does not care about people's intent. It only looks at the exceptions and says, if you've got a covered financial relationship, you have to meet an exception. Stark can't send you to jail. It's not a criminal law. But the penalties are up to $15,000 a claim, and some people I know think of that as being like a criminal law. Here's a list of the designated health services. So, a lot of stuff is, but for our purposes today, we're focused largely on inpatient and outpatient hospital, although in a clinic, it's good to know that lab, PT, OT, prosthetics and orthotics, DME all count. Back to storm chasing, Stark is the opposite of the anti-kickback statute. It's like sitting right here. And if you were to look at this, and you may say, is that a big deal? And if you look, I'm gonna take a chance here and see if I can do this. Look right here. There is actually a tornado on the ground in this picture, but it's hard to see. You kind of have to know what you're looking for because it looks like a sunny day. If you were standing right to the left of that, the sun is shining on you and it's not a big deal. Stark is a lot like this tornado. It can be easy to miss. Basically, I've created a disaster here. There we go. Stark is sneaky. So it's just much harder to do Stark. An example of how to do Stark is, or of how sneaky Stark is that it takes into account, you've got a phrase like takes into account. Is that different from varies with or different from based on? In common English parlance, no, it is not. But somehow, Stark tries to differentiate these things. So, Stark has quirks. The offending financial relationship can be completely unrelated to referrals. So, I think this is one of the really confusing things. A doctor's kid is mowing lawns, right? Mows lawns for the hospital. That's not a designated health service, so Stark doesn't apply, you would think. But it's a financial relationship between the hospital and a member of the doctor's family, so Stark is triggered. A maybe more real-world example is the child of a doctor becomes a device distributor, right? There's a financial relationship between the hospital and that person, and it's got to meet a Stark exception. Another really confusing part of Stark is that the term referral is incredibly broad. You would think that a referral is that if the person walks into the doctor and says, hey, I need an x-ray, and the doctor says, or I need crutches, and the doctor says, go to Walgreens to get your crutches, that the doctor has referred the patient to Walgreens. That's how any normal person would view the term. Here's the crazy Stark twist. If the patient, in fact, goes to CVS to get the crutches, the doctor has made a referral to CVS, even though the doctor didn't use the word CVS and actually affirmatively mentioned Walgreens, because Stark defines referral as creating a plan of care. So when the doctor says you need a service, the doctor has referred the patient to wherever the doctor goes for the service. That's weird. Another weird thing is that Stark defines the entity providing the service as two different things. Whoever bills for the service is providing the service. I think that seems logical. That's how it always has been. But then back in 2008, CMS expanded it to say that whoever could be, if someone is providing the service, they are also the entity for purposes of Stark. So you can really have two providers of the service. And functionally, this means that if a doctor owns a company that provides services to the hospital under arrangements, where the hospital is contracting with the doctor to obtain the service, that's what under arrangements means, you'll usually run into a problem if the doctor both orders the service and owns the company providing that service under arrangements. So some key concepts under Stark. First, the payment has to be at fair market value. And so that's generally going to be true. Now, there's an exception for this. You don't always have to have the payment be at fair market value. The big exception, as you can see from the asterisk, is in the case of indirect compensation. But generally speaking, payments are going to have to be at fair market value. Now, the payment also has to be set in advance, and it can't be based on or take into account the volume or value of referrals or any other business generated between the parties. And we got an asterisk. You're going to see a lot of asterisks on these slides. Referrals in this case is only designated health services. So you can't have a payment that varies based on designated health services that have been ordered by a doctor. That's kind of the plain English way of looking at this. Now, just a couple of minor examples. So I'm going to be not strictly legal here. I'm going to talk about taking into account, but not in the legalistic sense of the word. So let's say that a doctor owns an imaging company, and they want to lease it to the hospital for $500 a scan. If the doctor is ordering the scans, and some of them are Medicare and Medicaid, that's going to be a problem under Stark, because that takes into account the referrals, the scans, the doctor has created a plan of care for. Now, the same thing could work if the doctor is paid a flat fee and you meet the lease exception under Stark, and that flat fee is at fair market value. So if it's a per month rate, things could work. Or if the doctor isn't someone who orders the imaging, it could work. Now, under Stark, much of what we're going to talk about today relates to the in-office ancillary exception. So there are many exceptions to Stark. I'm not going to go through all of them today, but this is the strongest exception. And it's the strongest because some exceptions protect ownership, some protect compensation. This one protects both. So it's pretty magical. It has another magical power, which it allows doctors to be compensated for work that's done incident to their work. In other words, work done by PAs and NPs that they supervise, maybe if they were to order chemotherapy and some other services and supervise them. The in-office ancillary exception is going to allow that. This is a really complicated area because services done by a PA or NP aren't designated health services under Stark, and you really shouldn't need any special protection for them. But I think the government gets kind of confused about that. Okay, and more on that in a bit. So the in-office ancillary exception has a bunch of conditions, and especially people in clinics are going to want to pay attention to this, but hospital systems will too. So the group practice has to be a single legal entity with at least 2 physicians. Each doctor has to provide the full range of care that they provide. All the kinds of things that they do have to be provided through the group. Then there are 2 different 75% tests. In the first, if you look at all of the doctors who are in the group, 75% of their services have to be billed by the group. So, for example, if sometimes those doctors go to a hospital and the hospital bills for that service, that's okay unless 25% of the group's services in aggregate are billed by someone other than the group. Then you blow your group practice exception. And similarly, people who are part of the group have to do 75% of all of the physician-patient encounters. So if you were bringing in lots of outside contractors, that too can screw up your group practice. You have to distribute your income and expenses in advance, in a methodology determined in advance, which means you're not supposed to have retroactive adjustments to your comp formula, something that people I think sometimes forget. You have to operate it like a unified business with centralized decision-making, and you can't have any money or compensation that's based on the volume or value of designated health services. Now, you can break the group into subgroups and split profit amongst a subgroup as long as there are at least 5 people in that subgroup. So here are the kinds of things that can get you in trouble. First big question is, do you bill as a group? And one of the answers to that, look at box 33 of your 1500 form. If it lists a doctor name, not the group name, you're not billing as a group, and we've run into that with some clients. When you do a PSA, there's an interesting question as to whether the PSA can cause you to no longer have 75% of your services being billed in the name of the group. There is some preamble language that one could argue allows services where the group is expecting to get the money. Basically, if it's a group PSA, I've seen lawyers argue that you're okay and you don't run into the 75% problem. It's an aggressive argument. So I worry about PSAs and the group practice exception. If you get too big, you may not have a unified business or centralized decision making. And then sometimes your compensation formula will allocate profits in a smaller group that's less than 5 physicians. Another big deal is location. And location can become a big deal for ancillaries. Basically, this is really complicated. I'm going to try to explain this simply. And those of you who are following in your handouts, there are going to be extra slides that aren't in here that go into this in more detail. So you can, if this is intriguing to you, you can put an ancillary in a centralized location where you use that space exclusively. If you're a clinic, you can put your MRI off-site, your PT off-site, and as long as you have sufficient supervision for whatever Medicare requires, you're fine if you use that space 24/7. If you don't use that space 24/7, if you share it with anyone else, then you have to meet one of a few pretty complicated tests. The easiest of which is that you see patients 35 hours a week there and have a physician present for 30, then you're probably okay. Everything else gets really complicated. I'm not going to get into those weeds, but you can in the material. And I see we've got a question here. Does the full range of care mean that a general practitioner in a group with an orthopedic specialist wouldn't qualify? That's a good question. No, it's each doctor has to provide the full range of his or her services. So the general practitioner has to do whatever the general practitioner does. They don't have to, every doctor doesn't have to have the same full range of services. So hopefully that made sense. Okay, so that's kind of our location test. Now, there's a trick in the in-office ancillary exception. To use it, you have to give a notice to every patient that gets advanced imaging, defined as MR, CT, or PET scans. And so if you're a clinic, listen, because you better be doing this. If you're a hospital, you might want to do this. If you're a hospital, if you're a nonprofit health system, it's likely you can use the employment exception or another exception, and you don't have to rely on the in-office ancillary exception. But remember, using the in-office ancillary exception allows you to give credit more clearly for services that are done incident to a physician's service. So if you're hoping to credit physicians for incident to stuff in your health system, you may want to think about doing this. You got to give the notice at the time that you refer the patient for the service. So this is crazy. You can't do it when they come in. You have to wait until they get the order for imaging, basically. You have to give this to them in writing. It can be by email. And you have to tell the patient at least 5 suppliers that are within 25 miles. And suppliers doesn't include hospitals. You only have to include Part B places, doctors or independent diagnostic testing facilities. If you only have 5, if there are fewer than 5 such organizations within 25 miles, you list all that there are. If there are none, you don't have to give the notice at all. There's no ceiling on what you say in the notice, so you can say more. For example, you can tell people that that they should worry about insurance coverage and stuff like that. So let's talk a little bit about the compensation formula. Here's another trick that can be really useful if you're a physician group and less than 5% of your revenue is from Medicare and Medicaid designated health services. And no doctor in your group gets more than 5% of their compensation from Medicare and Medicaid designated health services. You can blow off the compensation formula thing. So that actually, I've seen multi-specialty groups that meet this test. I'm surprised at how often, because Medicare, Medicaid reimbursement is a small enough chunk of their stuff, and in particular DHS. It's not 5% of all revenue is Medicare, Medicaid, but is DHS for Medicare and Medicaid. Now remember, Stark does not require you to divide all of your money evenly. Okay, what does Stark require? Well, first of all, it technically only applies to Medicare. It's not even crystal clear it applies to Medicaid, although the courts that have interpreted it so far have said yes, even though there's a legal argument that the answer is no. The there are many ways you can compensate physicians that are clearly kosher under Stark. You can pay them for their RVUs as long as the RVUs don't include designated health services. You technically can pay them on RVUs and services that would be designated health services but are private pay, but A, be careful about state law, and B, I would not do this because the chance of screwing it up in $15,000 a claim, but federally, that's legal. You can choose an allocation and stick with it. So like, let's say you've got a spine surgeon in your group and you want to give them more of the physical therapy but less of the imaging. You can do that, and if you set it in advance and stick to it, that's kosher. You, of course, can do things equally. You can do it on seniority and pretty much any other combination of things above. There are many ways you can do this. It's not one size fits all. Some of the landmines to be careful about. First, make sure your agreements are written. Employment agreements don't need to be written. It doesn't hurt, but they don't need to. Almost every other agreement needs to be written under Stark. And that means the amendments need to be written. And all of us have worked on situations where a client has changed the terms of a deal, failed to write down those terms, and then had to struggle with an ugly Stark thing. So make sure that those, at a minimum, emailed, and you can make an argument that an email constitutes the writing, but that's not the way to do it. The way to do it is sign this thing for real. Make sure you know all of the relationships your doctors have, and that's good both for anti-kickback and Stark. And I think if you enter into a relationship, if you're a hospital with a doctor or a doctor with a hospital, have an auto-renewal term in it. I would argue it's almost malpractice not to, because it's so common to forget to renew those things. So do it automatically. You can always terminate the thing, but don't create an accidental Stark thing. Now, in the interest of time, I'm not going to spend much time on these slides. These are here really to just help people understand the difference between Stark and anti-kickback. Stark is civil, anti-kickback is criminal. We've talked about these differences. You can just sort of look through those slides if you want to understand the difference. A couple of other compensation laws that come up. If you are a nonprofit, a tax-exempt entity, you have to worry a little bit about the private inurement or private benefit rules. The good news is they're not that different from kind of the fair market value concept under Stark and the concepts under the anti-kickback law. I mean, being a little too cavalier here, and the tax exemption experts in our firm would roll their eyes at me a little properly. But conceptually, the big question is if the compensation meets Stark and anti-kickback, you're generally not going to run into a separate tax exemption problem. But it's another tool that the government has to pick on you, and in particular the IRS can come in and seek intermediate sanctions if a hospital is overpaying someone. Now, here's a quirky thing that has popped up a few times. The first time that I remember it popping up was with a pediatric surgeon in Texas some years ago, where the IRS has come in and said, if you're in a clinic and the shareholders in the clinic are taking money off of either non-shareholder physicians or ancillaries or physician extenders, that money needs to be treated as a dividend and not compensation. So there was that pediatric surgical case. We had a client get picked on this in a big way. And I am happy to report that one of my colleagues, Sue Ann Nelson, won the day at the end on this, and got the IRS ultimately to agree that no, this really wasn't a dividend. It was properly considered compensation. But this is an issue that's out there. The government is particularly focused on ancillaries for this, and words matter. Don't call things profit. Don't talk about you're distributing the profit from your non-physician practitioner or the profit from your MRI, because that sounds dividendy to be technical. And the government's going to argue you can't pay that out as compensation. If you want more on this, Sue Ann Nelson in our office would be really good on both if you ever get into this pickle or if you need risk management advice. My other our health law colleagues can help you on this too, but Sue Ann is really an expert. Another compensation area that can pop up is fee splitting, or as I often spooner it, flea spitting. Anytime a doctor is sharing revenue with non-physicians or with other physicians outside their group, you can run into fee splitting rules or fee splitting problems. It's usually in the state ethical rules, and it can get weird. Florida, we've got some Floridians listening today. Florida has interpreted its fee-splitting provision to say that if you've got a percentage management contract, a doctor is giving a percentage of his or her money to a management company, and that, in the government's mind, is a fee split. I think that's crazy, but that's how Florida interprets it. And just another thing to keep in mind, if you're a doctor and you've got a financial relationship with someone, you might want to give a notice to patients. All right, let's move on to one of the meatier parts of this, the relationship between hospitals and employed physicians. First off, remember, if we're in the corporation, we don't really need to worry about anti-kickback, which isn't to say like when you're buying, a hospital buys a practice, they need to worry about kickback then because they're not in yet. But once they come in the family, you're pretty good. Stark is big, and one of the questions is, are we talking about direct or indirect compensation? And this is a place that gets really complicated. I apologize. So if the organization that provides the designated health services is the same organization that pays the doctor, the compensation is direct. But more commonly, there's an intervening entity. You got to have a model like this, where the hospital is in one organization and you've got a medical group employing the physicians. So here, the hospital is providing the designated health services, the hospital care, and the money to the doctor is through the medical group, so you're dealing with indirect compensation. Now, I do have to provide a little asterisk there, which is, remember, if the medical group is billing for any imaging or therapy or the like, there could also be, that could be a direct financial relationship between the medical group and the doctors, okay? So that's usually we're going to be an indirect. So we're going to have to deal with an exception. And Stark looks at direct and indirect differently. When you're in direct compensation, you might meet the employment exception. But if the hospital is in any way subsidizing the medical group, then you probably have you have potentially indirect compensation. And if there is indirect compensation, you have to meet the exception. This if is a big deal, and we'll come back to that in a slide or two. Now, the employment exception is relatively straightforward. First, the services have to be identifiable. Now note, that does not mean they have to be identified in advance, and I'm in a fight with the government about this topic right now. Identifiable is not the same as identified. Remember, an employment agreement need not be written under Stark. It can, but needn't be. So identifiable means you have to be able to describe them, not that you have described them in advance. But keep in mind, the government often thinks you do need to describe them in advance. The payment has to be consistent with fair market value and not determined in an account that takes into, or the manner that takes into account the value or volume of referrals, so designated health services. It has to be commercially reasonable, even if there aren't any referrals. So if you've got an email that says, well, we would never pay them this much if we weren't getting their ancillaries, that's going to be a problem. And you can have a productivity bonus for personally performed work. Let's look at indirect comp. And this is one of the hardest areas I've dealt with as a lawyer. The plain English version is, does the payment from the hospital take into account the volume or value of referrals? I'd argue that's a mathematical question. Look at the formula. How is it calculated? The government wants to argue it's a metaphysical one, and we'll talk about that. So here's the regulatory text. And I'm going to focus primarily on Romanet 2. So if the referring doctor receives aggregate compensation from the last person in the chain that varies with or takes into account the volume or value of referrals to the organization that's furnishing the DHS, you have indirect comp. Now here's how I would put that into plain English. Does the clinic pay the doctor more if the doctor orders more designated health services from the hospital? If the number of patients hospitalized goes up, does the doctor make more money? And generally, the answer to that question is going to be no. The doctor doesn't get paid more for every inpatient or outpatient admitted. And so I would argue that there is not indirect compensation in most of these cases. Now, the government strongly disagrees, okay? They say that takes into account, that they try to read it as saying, that if the compensation is at above fair market value, it's still indirect compensation. The burden of proof is on the government, and the way we know that there are a couple of cases that says the government first has to prove that there's indirect compensation. Then, once they prove that, the burden shifts to the hospital to demonstrate that an exception has been met. Now, I should pause for a second to say here, there may be a difference between how you want to handle things in a risk management view of the world and how you want to handle things if the government comes in and picks on you, right? Some of what I'm going to talk about are ways you can defend yourself in the event that the government attacks you, and you may choose to be more cautious, right? So the government is going to have to prove each of the three things in that test. They're going to have to prove that that the hospital was compensating physicians for every referral. Note that in the text of the regulation, the word fair market value does not appear. And note that professional services aren't designated health services. So paying a doctor on RVUs doesn't create a problem under indirect compensation. But that's not quite how the government sees things. So the government will argue that if your compensation is above fair market value, they think that suggests the compensation takes into account the volume or value of referrals. Seems circular to me, but that's the government's position. Here's how the jury was instructed in Toomey. An indirect compensation relationship means that the referring physician gets aggregate compensation from and the entity in the chain with which the doctor has a direct financial relationship that varies with or takes into account the value or volume of referrals or other business generated by the parties. Fair market value, and actually backing up a step, Toomey is a case probably many of you have heard of. The hospital, we'll talk about it in a little bit. The hospital got a verdict that was, I want to say, $265 million. I think they paid somewhere like $72 million for compensating physicians for, including in the compensation formula, giving them credit for the technical component in a surgery center. Now, the indirect compensation exception makes no sense. To meet it, you have to have compensation that's consistent with fair market value and not determined in a manner that takes into account the volume or value of referrals. Now, I've never had a footnote before that simply read, but I do here. Because remember, in order to have indirect compensation, you have to take into account the volume or value of referrals. And here, to meet the exception, you can't take into account the volume or value of referrals. And this is why your hair hurts with Stark. I can't say anything more intelligent about this. It's just confusing. The exception also requires that things be commercially reasonable, even if no referrals are made. You have to have a written agreement that's signed by the parties, and you can't but if the last chain is an employment relationship, that doesn't have to be written, and you can't violate the anti-kickback statute. Here is the language of the indirect compensation exception. It's just in the slides. I'm not going to touch it with a 10-foot pole. In the Toomey case, the jury was told that the compensation is whether the contracts on their face take into account the volume or value of referrals. And that's an interesting wording, right? Because I would argue that means you don't get to look past the contract into the actual intent of the parties. So just that this is another defense thing to note. For Toomey, it says you look at the four corners of the contract, you don't look past them. The government disagrees with this strongly. I don't want to over-suggest this as the law, just something to note. Now, this next point, I owe a thank you to Adam Klein and John Fink at ECG, because I'd never thought about this. And it's really, this is a great example of how easy it is to get caught up in stuff and fail to understand complexities. And the question is, how do you slice compensation? The regulation says that indirect compensation looks at your aggregate compensation. Now, everyone always thinks of it as annual. Where did this annual thing come from, right? Why are we picking a year? There's no temporal demarcation anyplace in here. Why are you looking at it annually as opposed to monthly or daily or per decade? And honestly, I had never thought of that until Adam and John kind of pointed it out to me. And it's a really interesting point of how arbitrary it is to look at things annually. So in a case, the government has to show by a preponderance of the law. In other words, think of scales. They just have to show it's slightly more probable than not that you violated Stark. And they have to show that you had knowledge that you were violating Stark. And then here's the sucky part of Stark is that if you have violated it, every service ordered by the doctor is now improper, and the hospital isn't allowed to bill for them. And that's what makes Stark so awful, is it's draconian, which brings us to the following kinds of cases. And these cases don't go to trial very often because they're so expensive. Toomey I was wrong a little bit, it was $247 million. But the settlement was $72 million, and that involved 19 doctors. So you can kind of do the math. Where you see parentheticals here where I knew the number of doctors involved, I threw it on. So that gives you some ballpark of what the per doctor settlement is. And you can see these numbers are rather alarming. It's all gone up since the Covenant settlement back in 2009. I want to mention the children's situation because now I want to get into some of the craziness in here. This children's hospital in Florida got in trouble, and the allegation there was about a third of the doctors in that health system were above the 75th percentile in compensation. So let me just say that again. About a third were above the 75th percentile. Now, what percentage of the doctors would you expect to be above the 75th percentile? If it was a perfectly random distribution, about 25%. That number is not shocking, but the judge allowed it to carry forward, and that case settled for $7 million. And that brings to really one of the big parts of this webinar. I think the world has gone crazy in this area, and I think people don't pay attention to math or common sense. There are a bunch of, we have been lucky enough to work with some really good consultants on this and really impressed by them. But even they will say things like, we believe that we can defend compensation between the 40th and the 60th percentiles. Think about that for a moment. What they're saying is that they don't feel comfortable defending 80% of the physician market because only 20% of doctors are between the 40th and the 60th percentiles. I see all kinds of things suggesting that the 50th percentile is some sort of fair market value ceiling. And people who are, quote, aggressive would say the 75th percentile is a ceiling. Well, that means 25% of the doctors are above fair market value. That's crazy, right? I would say the 90th percentile isn't a ceiling. Some people, 10%, are above the 90th percentile. The wisdom in here is crazy, and I think that there's a serious lack of analysis. Then, that's only one of the problems. Fair market value is not supposed to consider referrals. How do you find a comparable that doesn't have referrals in here? So this stuff is extraordinarily challenging. Let's talk for a moment about surveys, because I think that the surveys are used really poorly. And I owe a huge thank you here to Tim Smith at Ancura, because he's writing a book right now. You can see the site there. And he talks with Megan Wong at MGMA, who says, look, these data aren't intended to be an academic data set for extrapolating to the U.S. population of physicians. It's not a one-to-one representation of the universe of medical practices. And if you dig into the data, MGMA throws out highs and lows, all right? This is not a mechanism to say any amount above this is unreasonable. I worry about whether people who complete these surveys know what total compensation is. I'm sure some people are including call coverage and other stuff in there, and others are not. And MGMA expects you to if total compensation is in, but if you get disparate stuff in there, things don't work very well. Now, one of the points that a number of consultants have made to me, I still struggle with this one, but the conventional wisdom amongst the experts is that there's an inverse relationship between the per RVU compensation and a doctor's productivity. In other words, if you're a low-producing doctor, you'll make more per RVU. And on some level, I can see how that makes sense, right? If you're just starting out in practice, they'll pay you more. But I know in the legal world, if we've got two lawyers, so I'm sitting here with Katie Ilton, she's a hard worker and I'm lazy, we have to take overhead out of each of us. if she brings in more, or let's say we bring in, bottom line, the overhead nuts coming out of each of us, she's working harder. She's going to get paid more per hour than I do. And it should be true in a physician world too, that the highest producing doctors, I would expect, would get paid more per effort of work because the fixed overhead is being shared evenly between the two of them. And so I don't understand on some logical level how this happens. But that's one of the data points out here, and it's another place I think the data is kind of irrational. Okay. This is a discovery. I was shocked to learn this. So first, if you look, let's just say at interventional cardiology. Pick 2012 as a random year. According to AMGA, the 90th percentile interventional cardiologist was at $102. MGMA has them at $86. That's a really big difference, right? Here's another little stunning thing. When I had this epiphany, it caused me to realize what's really going on with these surveys. Do a linear look at what the 90th percentile for RVUs was in interventional cardiology. Look at the variation from year to year. And I am going to posit that there is no way that doctors in aggregate across the country change their production radically from year to year. There might be little tweaks, right? But the doctor who's working at the 90th percentile in 2009 and the one who was in 2010 are about the same. They're not 2,000 RVUs apart. There's not a 20% swing from 2010 to 2012. That tells you there's something going on in the surveys, and they should not be used scientifically. We lose money on every physician. If it's true, I think you've got a giant stark problem, because is it commercially reasonable to lose money on all of your doctors? Now, I don't think it's true, but it's viewed as axiomatic, and one of the things that scares me is how many emails there are out there. If you go ask in the hospital CFO world, I think everyone says we lose money on all of these doctors. Now, so why do I think it's not true? Well, first of all, I think that in a lot of these calculations, overhead is being thrown onto the doctors that's probably not properly thrown on them. And there are various ways it can do it, right? So first, maybe this is a fair allocation. If the office is nicer when you're in a health system than a doctor would ever have if he or she was in private practice, should that be allocated to them or not? I guess reasonable people could differ. But a whole bunch of expenses that physicians in private practice don't incur, but that exist in a health system and get thrown on them. And that can be a useful tool if you want to try to pay the physicians less, for example, or if maybe it's even fair and maybe it's even kind of accounting 101. But for purposes of Stark, throwing that on the physician creates a giant problem. The ancillaries are out there, and how, if in a private practice, the ancillaries count, and it's part of the calculus. And how you handle that in the hospital world is tough because you don't want to run into Stark. But the real world that is part of the cost-benefit analysis of having those doctors there. And I think that's a hard one logically. But stamp out this, we lose money on every physician. It's pretty much guaranteed to cost you money. All right, last Stark slide. Beware of bad lawyering. I owe some of this to one of our colleagues, Pari, who would maybe be co-presenting with me, but she's a new mom, so she'll be back soon. So she was doing some research into cases and found that 4 cases all rely on the same Medicare manual language that was written in 1992 that the courts say was written with Stark in mind. And it's a discussion about hospital services. Well, Stark 1 came out in 1989, but it only dealt with lab. There were no hospital services covered then. Stark 2 was passed in 1994. So there is no way that the language written in 1992, unless someone was prescient, was talking about hospital services in Stark. There are 4 reported cases out there where none of the lawyers caught this. Stuns me. A bunch of money was spent in that litigation, and no one figured out that the core of the whole thing was poorly faulted. So I will just say, good lawyering matters on these things. Choose your lawyer wisely. All right. Now, I've only got 10 minutes left till the top of the hour. We will fly through chunks of this, and like I said, we'll run a little past the top of the hour. So gain sharing, another form of compensation. And you could spend 45 minutes talking about that. You don't need to. Gain sharing is a lot like this. It looks kind of pretty, and it's a great thing to do as long as you're careful. Don't stand right in front of the tornado. If you do gain sharing carefully, it's legal. It's a good thing, I think. People use all kinds of labels to describe it. You could call it shared savings, co-management. I don't care what you... I kind of like shared savings myself. Of course, CMS then used that term for ACOs, but such is life. The main idea of gain sharing is save money. If physicians contribute to that saving of money, they can share in things. Maybe they'll lower implant costs. They'll avoid opening up cell savers, or, I know companies or hospitals have saved millions of dollars by not opening up surgical packs, and they've saved it in sterilization costs. Money matters. You can easily get so focused on gas prices that you miss the tornado in that picture. So the federal laws that we've talked about all apply here, but it is crystal clear that gain sharing is legal. That is one of the easiest legal pronouncements. How do we know it? There are 16 favorable advisory opinions, and the OIG has said, look, we don't intend to look at gain sharing unless there's a lack of inpatient program safeguards. Basically, you want to try to maybe cap payments, and I think one of the biggies is disclosure. If patients know what's going on, the risk is quite low. So a couple of questions. How do you split the savings? All the advisory opinions to date have been 50-50. You have to be 50-50? No, but that's just kind of how things are gone. Can you do this with employed physicians? And my answer to that would be sure, why not? So if you're in a system right now and you want to do some kind of co-management deal with your doctors, can you do it? Yes. Can you have long-term payments? And this is another answer where lawyers differ. Many will say you can only do it for 1 year, but they're ignoring advisory opinion 1222. And of the 15 advisory opinions, that's the only one I know of that blessed a deal lasting more than 1 year. But you don't, you only need one to know that it is possible to have a deal that lasts more than 1 year. I had a lawyer who said to me, well, that's about co-management, and therefore it doesn't apply. Well, the word co-management appears in the advisory opinion. That's true. But if you look at what's going on, it's talking about shared savings. Just an aside for the physicians who are listening, if you do a gain sharing deal, do you need to create a new entity? Not necessarily. If you've got multiple physician groups in it, you may want to. But if it's a hospital and one group getting together, I think it's probably unnecessary. It's an unnecessary expense. And then the doctors will want to make sure that they have true control over the factors that are present. I've seen deals where the doctors are evaluated on Press-Ganey scores, which can be driven by things like how good the food is in the hospital. Remember, under CJR, there are quality metrics in there that the doctors have no control over, and you want to pay attention to that. If you don't know what I'm talking about and you're in a CJR, we have a webinar on CJR, and send me a link. I'll send you a link to that. You want to make sure whatever you're getting paid on is stuff that you can control. So on-time starts is a reasonable metric, but it has to be your present, not that the case starts on time, because you as an orthopedic surgeon or a cardiologist can't control whether anesthesia is present. And if you're the anesthesiologist, you can't control the orthopod. I'm going to do this one really quickly. It's the hidden trap. Just like the car here is about to just missed getting swept up by a tornado that was on the ground in the dark, I want to tell a story about the perils of email. This is out of the Des Moines Register. So a patient who happened to be a nurse at the hospital called and said that her cardiologist made a startling confession. She would have fared better if they had another brand of pacemaker, but the hospital had leaned on him to install a Medtronic model to help the hospital collect what he called a kickback deal. All right? This is that's how the Des Moines Register reports this episode back in 2006. Well, you look at what actually happened. Here's one of the emails. So the doctor has made no attempt to comply with the contract. I'm prepared to reschedule his devices and to be in compliance with the contract, says the hospital manager, who has since left the company. In another email, Butts, who is the administrator, said, the doctor said he would abide by the contract that paid him money for compliance. The hospital chief operating officer happened to be named Stark, which is almost coincidence. Isn't there a joke along these lines? Now that we've established what he is, we're simply negotiating over price. This was a perfectly legal deal that people described in really bad terms. Be careful about what you put in emails. So, I mean, that's the great example that a perfectly legal deal can become problematic if people describe it carelessly. All right, I'm going to move on to a couple of more relationship type things. Call coverage. Can you do call pay? Yes. I think that's an easy yes. You just have to make sure it's at fair market value. If you're a physician listening to this, you want to make sure that you get it, or actually both sides. It has to be in writing. That's the Stark Tiger trap. Don't have an oral agreement. And if you're the doctor, make sure that there's nothing in the agreement that sort of adds requirements to you that weren't already present in the medical staff rules. PSAs are increasingly common. I was just talking with Jim Platt and Steve Beck, two of my super smart. It's nice to be the dumb one in the group. So I'm talking to the two of them. And we're talking about PSAs. And all kinds of people seem to think that when you enter into a PSA, you have to compare the payment under the PSA to what reasonable employment comp would be. That's not right. When there's a PSA, the doctors have a whole bunch of overhead that they're encountering, and comparing employment compensation to PSA compensation massively inaccurately looks at the problem, and you're going to wind up undercompensating the physicians. And a lot of the smart consultants out there get this, and we're glad that we work with those. If you do a PSA, just remember the things like there are tricks out there that get you in trouble. You can't bill incident to for hospital-based stuff. You got to pay attention to the 72-hour rule. This isn't really a topic about this, but I just threw this slide in as a reminder. Recruitment, we're not going to spend much time on because I don't think recruitment is a great way to get a lot of money, but it is a mechanism that hospitals can use to compensate physicians. It's a fair amount of hassle, but it's a little bit better since 2007. People still sometimes think that you can't have a recruitment deal if the clinic has a non-compete with its doctors. That is not true. As long as the doctor's non-compete is reasonable, you can have one. Okay. The last thing we're going to do here, actually I'm going to take a couple of questions now, and then we will move on to relationships with drug and device companies. So this is a question. So if a hospital employs all of the doctors and the CFO says, we lose money on our physicians, is that something you'd consider a Stark problem? And I would say, I guess, if it's true, yes, I think it's a Stark problem. I don't think it's true, but boy, I want to stamp that thing out. A physician group donates money to the hospital foundation, gala, or golf tournament. Is that a compliance issue? So first of all, there's an interesting long-standing debate about whether money from the doctors to the hospital is a compliance issue. And I think that there would be arguments that the answer to that is no. Certainly from a policy standpoint, that's not what they're trying to get at. In fact, if anything, they'd be getting at more the opposite. They'd be getting at the hospital contributing to, but I would say if it's a hospital foundation, the odds of this being a problem are pretty low, generally. All right, so if this one is really a focus between relationships between drug and device companies and doctors now is how we're going to bring this to bear. Those of you, we did a webinar on this about a year ago, so if you've seen this, this is going to be a rehash and you could sign off. So I often do the reminder that sales staff have an incentive to characterize things as permissible. And it's okay. I mean, I help sales staff for device companies give reimbursement advice. It is, in fact, I would say good that they do it. But when someone who is selling you something gives you advice, just make sure you check it out, because a lot of salespeople are really good. They know the stuff better than anyone else. The rogue salesperson scares device companies, it scares drug companies, and it should scare the people who buy from them. So make sure your person hasn't gone rogue. So you've got an off-label use of a device that helps cardiac patients, and the doctor asks, the company asks a doctor to give a speech about the merits of the device. Can they do that? No. You can't do off-label promotion. That's a problem. All right. Now compare that to can the doctor use something off-label? Yes. And I was just reviewing something yesterday for a client. A drug company had an agreement where they made the clinic promise not to do off-label use of a drug. Off-label use is fine. Off-label promotion is the problem. And the difference basically is, are you encouraging, are you getting paid to encourage people to do it? A device rep says, hey, we really want your advice, doctor. We'll give you $200 an hour if you'll come out to San Diego and attend this session for us. Is that a problem? Well, if you think about the various things, is it a Stark problem? This should not be a Stark problem because, you know, it's not a Stark issue. That was a little circular. Because the drug company doesn't, it's not a designated health service, so Stark isn't an issue. So we can blow Stark off. Now, is there a risk that the drug or device company is paying the doctor to influence referrals? There's a risk of that. And so I want to know, why is the payment happening? You know, why are we going to San Diego? Could this have been done someplace else? Are they meeting for 2 hours every day for 5 days and it's really a long vacation? Or is it they meet for 8 hours for 2 days? Those to me are very, very different. And I remember watching the TV news locally where one of our local news stations, Fox 9, caught one of our clients at the baggage claim and walked up to him with a camera and said, we understand it was actually San Francisco. You were just in San Francisco at this conference. You went to, what's the name of the prison now? Alcatraz, which is kind of ironic given the topic of this thing. You know, you went to wine country. Why were you getting paid so much to go out there? And the optics of that one were really bad. It isn't automatically illegal. It's sort of this it's a smell test of, was the compensation reasonable for the work that was done? Intermediate sanctions, that's the IRS stuff. Well, assuming the device or drug company is for profit, we don't have to worry about that. You do have to worry about state law, and it's easy to lose sight of state law. You know, we've got people on this webinar, I didn't count it up, but I'm sure it's at least 40, and sometimes we have all 50 states, right? And they have really disparate laws. You know, we've got people from Hawaii. You know, there are fewer laws in Hawaii than New Jersey for whatever reason. So just know your state law. A drug rep offers the doctor $200 an hour to listen to their explanation of why the drug is better. Is that getting concrete? And I'd say that that's getting a concrete wall. I think that doctors have to learn about stuff, and so getting paid to sit and listen strikes me as problematic. So an orthopod and a family practitioner are good friends. The orthopod takes the family practitioner to the best restaurant in town to celebrate the family practitioner's birthday, and the bill's $350. This does not stress me out that much. I'm assuming that they really are good friends. I'm not lying awake nights. Let's reduce the amount of money to $100, but have the doctor run the expense through the practice as a business expense. I'm a little more worried about it now. I don't like it as much because it feels like then they're not being friends. It feels like they are, and I could defend this, but I would prefer not to have to. This is one of my favorites because this is one of the very first things I worked on as a lawyer, was something akin to this. A drug company wrote a letter to a client of ours saying, because this involves patient care, it can't be a kickback. So let's look at this situation. You get a free treadmill if you prescribe this device 10 times every month. But since it's to help patients, it can't be a kickback. True? Absolutely not. There's no such thing as a patient care safe harbor. If something is of economic value to a physician or the group, it's a potential problem. And I don't think it matters whether it's in kind or cash or whatever it is. $500 is $500. And so if it's a $10,000 treadmill or a $10,000 cash or a $10,000 fellowship, they're all the same, and they're potentially problematic, and you have to look at the why. And if the why is because he ordered our thing 10 times, I hate it. At the other extreme, you buy a bunch of devices wholesale, and you're billing the insurer for them. Let's say you've got an ASC. And the device manufacturer says, if you buy 10, they're $1,000, but we have a volume discount. If you buy 100, they're only $800. And after that, we give you an additional $100 rebate on every one. Is that problematic? I don't think so. I think that's totally kosher. And all kinds of people get nervous about it. And part of it is because the word volume is in there. It's a volume discount. In fact, I just read a contract yesterday that said, in a volume rebate, none of this discount is based on the volume or value of referrals. And because clearly someone was worried that if it was based on the volume or value of referrals, it's illegal. Well, of course a volume discount is based on the volume or value of referrals, and that's okay. So why is it okay? It's just a discount in price, and I think a kickback requires a third party to be deceived. If your purchase price is discounted, as long as you're not getting paid on a cost basis and inaccurately reporting your cost, you're okay. So I put that poorly. If you are not paid on a cost basis, I think any discount is basically going to be okay. If you are paid on a cost basis and you properly report your cost, I think you're okay. So the only time a discount is a problem is when you lie in your cost reimbursement. Scholarships. This is really our last couple of things here. You want to train a nurse on a device pump, and there's a seminar in Orlando. Can you ask the device company to pay for your nurse to go out there? I'm a little nervous about this one. If the device company chooses to do the training for everyone in one place as opposed to train them in individual practices, that I'm pretty okay with. But if there is some conference that happens to be in Orlando and you go and ask it as a doctor the device company to pay for it or the drug company, I get nervous about those. By contrast, if there's a scholarship offered by a company that they they're helping poor low rural practices that maybe have a poor economic model, I'm going to be less worried about that as long as there's separation between the device company and the person who's making the decision about the money. And then the last one, a drug company offers to give a $50,000 fellowship to hire a new physician assistant. And we see these still to this day all the time. This makes my stomach churn. I hate this. But I have seen it a lot, and I see administrators who want to bend over backwards to say it's okay. And this one makes me super nervous. So I probably put too much material into this period of time. We whipped through it a lot. Katie, do you have any more questions at the moment? So for those of you who are bored with me, and actually bored might be the operative term here. If you bared with me, whatever it would be, now it sounds like we're at a strip club. I don't know. In any event, the next conference will be Kevin Rich talking about what's going on in the False Claims Act world. He is smart. He is entertaining. And I don't know what day he's going to be here. So thank you so much for listening, and have a great day.